It has been a really long day, and I think it has been a very rewarding, long but rewarding day. And I think Professor Karamasis deserves all the congratulations for bringing this into a very successful conclusion. I think we enjoyed wonderful lecture, wonderful talks, wonderful discussions. And I think we are now approaching probably to the most, let's say, important part, because it's the closing of the day, and the experts, the international experts, are now going to tell us about how we're going to shape the future. This is very, very important. And I have to say that a few years back, quite a few years back, I challenged my mentor. He's a very well-renowned interventional cardiologist in Greece, and I told him, okay, what do we do with interventional cardiology? It's just only a mechanical procedure. It doesn't deserve any brains. And he looked at me and he said, okay, you don't get it right, because through interventional cardiology, we learn the physiology. The techniques and the stents and the procedure come and go, but the physiology stays. And I think this course is about physiology, is about what is going to stay in the future. So we want from you, from the international experts, to tell us a few words about how we're going to shape the future. And first, we have Dr. Biscaglia. So a couple of words about how we're going to shape the future.
Yeah, I basically don't know. That's the first point.
That's a good start. That's a good start.
So I don't know how to get out of here. So, no, I think that we discuss all day how to make it feasible, because we understand that physiology and imaging are our future, but the issue is that they have to be feasible in all cath labs. So it's not that you can do it just if you are in, fancy reality with, money and everything else. So my view is that we have to find out which is the best tool for that patient. So for example, were discussing about MI patients, so the evaluation of non-culprit lesion in the MI patient, and my view is that the future there is angio-derived FFR, because you can spare a second procedure just to perform physiology, and you can use the projection performed during primary PCI to understand whether a lesion is flow limiting or not. In the stable setting, I think that CT, we have seen many cases today, and each cases we were discussing, okay, if I could have a CT FFR in that case beforehand, that would have been helpful. So I think that the future there is to perform a CT FFR before angiography, and to integrate the anatomic information you can get from CT with physiology, in order not to over-treat the patient, so start from the physiological standpoint and understanding the pullback curve, which part of the vessel is really flow limiting, and then, especially in the more complex setting, starting with PCI, already knowing the catheter, the amount of calcification, the plaque burden, the need of rota, IVL, and so on, before to start the procedure. That would be very important also from the organizational standpoint. My last point would be, for example, in non-STEMI, for example, it would be interesting. Abbott is working on the integration of physiology in the OCT probe. So probably in the next years we will start to use it and to have experience on it. So my view could be, for example, in non-STEMI patient, where the assessment of the culprit lesion could be tricky to perform OCT and to understand which one is the culprit, and then probably to perform a physiology assessment based on imaging in the non-culprit lesion. That would be a possibility.
Excellent. So I think that you touched the very heart of the issue, which is to have cutting-edge technologies, but also apply them in a more, let's say, democratic way, which means that to be applicable to all patients. Exactly. And this goes through the identification of the patient characteristics, and maybe go to a tailor-made procedure. And of course, the main issue is to combine imaging with physiology, right?
Exactly. That's my point.
Okay. Now, to the next. We'll take it as it is in the program, if you don't mind. So it's Dr. Guagliumi now. So looking at your own crystal ball, can you see the future, or you have a different?
I don't know what do you have in mind when you say the democratic. I think, in my view, means properly used. And we got a lot of examples today that is essential. Also in the tools that we have already available, the appropriate use, avoiding pitfall, using the entire measurements, using the longitudinal view is essential. And the combination of the two seems to gain a lot of potentials in the future. In which way? We saw hybrid technology. And what is coming, what is going on, is to get together this technology with potentially smaller catheter that still represent some trouble when we are confronting with a complex disease and calcifying tortuous vessel, expressing eventually the components of physiology and imaging. It went from the CCTA and the possibility to get plaque characterization and physiology anticipation for planning, I think is going to be reflected also for invasive imaging as soon as possible. The last words is toward AI. What does it mean in terms of impact? Segmentation, automatic detection of the plaque for helping the expert? Not. For helping the vast majority of the people and becoming democratic. And the final point is we don't want to see anymore that the two major predictors of using are the hospital and the doctor. Because I think if we are producing convincing data, it should be used. Otherwise, it's very, I think I'm desperate when I'm watching to the Italian Society of Interventional Cardiology reporting the rate of use of physiology and images is dramatically low. And so we need, when we have the evidence, we need to use it. And the cost is not the main limitation.
That's a great comment, and I think that, as you said, we need much more evidence, and all of us are quite in a hype with artificial intelligence these days. But artificial intelligence is based on data, good data, because if you put garbage in, you're going to get garbage out. So I think what you are pointing out is very, very important. Having good evidence and combining all the appropriate data, you're going to end up with the use of artificial intelligence into shaping a better future. Excellent. Now, Dr. Milasinovic, please.
Thank you very much. So I would like to start with a bigger picture. So when you look at the field of interventional cardiology, I think that the structural diseases seem to dominate in terms of investments and everything else. And then the question is why? And one of the answers could be because that's innovative, that's an innovation. And in the coronary space, there is not much more to offer. If you think about primary PCI and the widespread use of it, it helped save patients' lives. And yet we spent a whole day showing how coronary interventions can improve. So when we think about the coronary space, imaging physiology and potentially drug-coated balloons, I think are innovations which will change this field over time. And I think it is our also job to explain to the community that that's important. So that I see as the first near future goal for all of us, saying that, of course, structural field will expand and should expand, but we should bring imaging and physiology to the forefront of coronary interventions and explain that that's where the innovation in coronary interventions is. The challenge is that the effects of imaging and physiology are not immediate. So basically, by improving our procedure, we improve the long-term prognosis. And that, I think, is the biggest challenge, because when you implant TAVI, and I do that, of course, you see an immediate effect. When you do primary PCI, you see an immediate effect. So we need to explain that imaging and physiology is investing into the future of the patients. And I think that is the narrative that we need to spread as much as possible. So now I will attempt a guesswork about the near future, mid-future, and distant future of coronary interventions, given what I said. So I would say that in the near future, with regards to the imaging, what I think needs to happen is boost the adoption. I think that we've seen a lot of trials. There will probably be new trials. For example, this year, I think the optimal left main PCI should be released, which is IVUS-guided left main PCI. So there will be trials on imaging still, but I think that the main challenge will be adoption. And to increase the adoption, I think that education will be the key. So that's the near future for imaging, I would say. The near future for physiology, I think, is less certain, because I do not see that the adoption of physiology will increase in the near future. What I think is that it will probably remain stable, and that there will be some development of angio-derived technologies, and we will see how that will fare. So where I see that physiology will make some impact is mainly in the INOCA field. And of course, if we can bring out the message that it can guide the procedural planning with the longitudinal vessel analysis. These are new concepts, but I think that it will need a lot presence at congresses that the community accepts this. I think there is a steeper uphill battle for physiology than for imaging in terms of adoption in the near future. Thinking about the mid-future, I think that making everything we do automatic, let's say in the next 10 years, will be probably something which can be achieved. So anytime that we do angiography, anytime that we do IVUS or OCT, anytime that we do physiology, artificial intelligence may tell us whether we have a reliable measurement and what this measurement may entail, so that we as physicians choose from it. And then a very, very distant future, I think, that we may move towards what really is the goal, and that's personalized medicine, and that is integrated all possible information quickly and reliably. We do not do it reliably today, to be honest. We spend the whole day interpreting imaging, and Simone told us that his opinion is that the use of QFR led to the results of the FAVOR 3 trial. So that's not reliable use of imaging and physiology. It will become more reliable once it becomes more automatic, and I think artificial intelligence will help us with that.
No, that was really great. I really liked your approach about the imminent, the midterm, and the long-term future. And I think what you pointed out is very, very important, to have each of the two approaches, the physiology and the imaging, to the place that they belong, because each one of those has a different way of absorption, of implementation, and unless we explain that to fellow doctors and to the patients, we're not gonna get it combined to the appropriate, to maximize the benefit from their combination. And last but not least, Dr. Keeble.
Yeah, I'm not going to be anywhere near as eloquent as that. I thought that was a beautifully described answer. I would go for unmet need. I think that's where we always have to focus our attentions. That's my belief in research and in clinical medicine. So I think the CT-FFR is the gatekeeper already, and it should be. And if it's not, that's a problem. We've got to fix that. We've got a problem in the UK. We still don't have enough slots. But to go into it in a safer way. Second thing is symptoms of stable patients. I think we're still really bad at deciding which symptoms are ischemic and which are just nipple pain. And I think we do have to be really careful. If someone's got atypical symptoms which are clearly not cardiac, there is no point in intervening on their proximal LAD or anywhere else for that matter. And I think we're part of the Orbiter group, and we're learning a lot about symptoms, and I think that it will be really important in these stable groups of patients. I think if we look at the other unmet needs, I think it's cardiogenic shock and STEMI. If you look, the data for both hasn't really moved forward in the last 10 years. So I think going back, we've got to personalise and identify the patients who are in early cardiogenic shock and have better treatments for them, and we've got to have patients that have early signs of microvascular obstruction in STEMI and develop new trials and drugs to show benefit in those patients. And I think we've got to personalise the patients rather than put 1,000 anterior STEMIs in, of which 50% of them would do just fine with revascularization. We've got to pick that 50% who have got a bad problem at the time on the cath lab and do something to them there and then. So I think going back to your point, personalising the care for these high-risk, unmet need patients is really, really important. Finally, I think imaging we do need more image interpretation to help the interventionist, because a lot of our colleagues who don't use it is because they maybe haven't had the opportunity of using it, the education, the support, and don't feel empowered to use it. The data's there. We're not going to get any more data. We don't need any more data because there's overwhelming amounts to show that imaging improves outcomes. So we've got to understand why adoption has not taken off, whether it's due to funding issues, whether it's due to training issues, whether it's due to institutional issues. We don't know, but we've got to improve that to improve the outcomes of our patients. Then I think the other unmet needs that may be filled are reducer-type therapies for refractory angina. It appears to me they work, and I think we're going to see a whole host of things that go into coronary sinuses over the next 10 years, because I do believe it's a therapy that works. And then finally, I think we're going to see all of the things that we do invasively, whether it's complete and full microvascular assessment or whether it's near-Zivus of non-culprit. I think we're going to see that integrated into CT, into non-invasive ways of doing it, because that's what all of us and our patients actually want, even though we are biased being interventional cardiologists. We want a CT that says that circumflex's got a crazy high-risk plaque. And then we want to develop personalized medicines. And let's face it, it's going to be pharma that fixes most of this. It's not going to be stents. It's going to be pharma. And we need to develop drugs that are hopefully not high cost, that are personalized, that affect that plaque in a much more personalized and better way to reduce the vulnerability of those plaques. So, but I think we need to say, get the information. I see a phase of the next 10 years learning invasively with near-Zivus and with coronary physiology, with absolute flow, absolute resistance, all these beautiful techniques that we have that will then be, if you like, the gold standard, that then we need to get non-invasive ways, CT and others, to then correlate the two so that we can do it all outside of the cath lab if we can.
Now, that was very important, because you describe interventional cardiology and what we learn as a stepping stone into going actually backwards and leading ourselves to prevention and preventing the event. We can treat very effectively with interventional cardiology now the acute or the non-acute event, but we are very, how to say, pragmatic and very successful in this, but we have to go before that and prevent the event. And I do also like what you said earlier, because during this day and all these other congresses and discussion and meetings that we have, we are discussing about cutting edge technologies. We are capable now of doing many things that couldn't do in the past, but sometimes we are carried away, and we think that we can, let's say, because we have a very good visual result, we solve the problem. But as you said at the beginning, we have to think about the symptoms of the patient and the clinical setting, because this is all we should care about in the first place. Now, I think the last words belong to Grigoris Karamassis, the heart of this Congress. Grigori.
A lot. I want to thank everyone for being here. I want to thank Simone, Tom, Dejan, Giulio for traveling outside Greece to join us and share their knowledge and their expertise. And finally, I want to share our cath lab team in Attiko for all the work that we are doing every day. Thank you very much. See you next year.
See you next year.